Thank you for inviting me. Yes, I was the lead author of that paper, but to put it into context, it was pre-COVID, so it was before we had the weekly GLP-1 receptor-based medications. So as one could argue, a lot of things have changed in the last 5 and even 10 years. Firstly, prior to then, we didn't have an active campaign to inform people in the community about obesity as a disease, not a lifestyle choice. But also at the time of that survey, we only had the generation 1, the first generation of obesity management medications, which are effective, with lifestyle intervention and those first generation medicines. People on average would possibly lose about 8 to 10% of their starting weight. And with that comes some significant health improvements. However, really it was in the last 5 or so years upon the newer generation of weekly subcutaneous GLP-1 receptor medicines that we've seen a big shift. So as you correctly pointed out, we are now seeing people living with obesity proactively coming and asking about obesity and if they're suitable for these medications. So as a doctor, I'm very comforted by that fact. It's great to see them come in and ask. Not everyone is suitable, but at least it gives us the opportunity to have that discussion and to determine if they are suitable or not.
Education of healthcare professionals, but also of the wider community, and making sure that even the facilities have the right equipment to be able to manage this.
It's really an amalgamation of the data that we had to hand and also utilising the Edmonton Obesity Staging System to help stratify which patients could be managed in primary care and what therapies we can do in primary care versus those that might be a bit more complex or those who have had a non-response to other therapies and therefore need to be referred to specialist care, or if they are already at higher levels of illness, so Edmonton stage 3 and above, they need to be fast-tracked to a specialist unit. So it's really putting together the fact that it's not just BMI, it's actually how sick the person is, what complications they have, do they have visceral adiposity, because we know that's quite harmful, and looking at the patient holistically. So it's been quite a good resource. It obviously is an article, but we have distilled it to an algorithm, like a flow chart, which is only 1 page, and therefore easy for clinicians to just streamline and say, okay, my patient falls under here, evidence-based what we can do, whether it's lifestyle plus very low energy diets, lifestyle plus obesity management medications, or combinations thereof, and when do they need to be referred for more complex possibly combination therapies and or bariatric surgery. Very practical and evidence-based, and it's a fluid document. That's what I wanted to say. So we are every year to every 2 years updating it as more and more therapies are becoming available. So we do have the issue of resource allocation, and in Australia, unfortunately, there is no medication to treat obesity that is subsidised by the government. So everyone has to pay for themselves. And this is a significant barrier to treatment because we know that the people who are the sickest, so higher BMIs, higher Edmonton obesity staging scores, often are actually the lower socioeconomic people, therefore have limited financial resources. So the ones that need it the most are less likely to access it, whether it's medication or bariatric surgery. So there is that inequity there, and that is something that I'm passionate about as an advocate, trying to get the government to review this and try to address the problem. So there's the issue of access. Then there's the issue of if they do go on the treatment, many patients often have unrealistic expectations, as you mentioned earlier. An important finding from the action study that we did in Australia, because it helped to shape our consulting and refine it. So because we saw there was a big disconnect or a big barrier between what patients were hoping to lose versus what the evidence told us medical science could deliver, and then offsetting it against what we know from the science, how much weight loss different health conditions require to see some improvement. All right. So there were 3 different components and they weren't aligned. So essentially what I have found a very useful tool, and I also teach medical students and other doctors that come in for learning obesity management when they sit with me. I have a slide on my PowerPoint slide on my desk and on my desktop, and I often will ask the patient, having looked at their medical history, I write myself a little summary looking at the medical, mental health and metabolic complications. So I've got them in that kind of Edmonton's Obesity Staging System format. And then I ask the patient, now, why do you want to lose weight? And mostly they will say, oh, because I want to be healthy. Of course, but I then ask them, I want to know, make me understand what is being healthy look like and feel like for you. Because everyone's why is going to be different. And then I jot it down and then I ask them, could you let me know how much weight do you think you need to lose to improve your health in the ways that you just mentioned? And then I jot down what they say. And if it's very surprising, I might say, can I ask, was it a doctor or some social media site? Like, where did you come with that number? Just to get them to reflect on where did this number come from. And then I say, okay, well, let me show you this slide. And then the slide has, it's basically 4 columns, and it breaks down the percentage weight loss in various groups, up to 5%, 5 to 10%, et cetera, et cetera. And then I've got listed about half a dozen different comorbidities that improve that amount of weight loss. And then I invite the patient to help me look for their health conditions in those columns. And then we'll say, oh, you have type 2 diabetes. Okay, let's have a look. Oh, that's in the 10 to 15% weight loss. So that's our goal. And then if we lose anything above that, that's an added bonus. And that helps us to bridge the gap, because I say, well, this is the data. That is almost like the umpire. It is the one that is helping us to make that decision. It's not me, the doctor, the cranky doctor, or the too strict doctor. No, I'm just saying this is the data. But the emphasis is about improving health and making sure that any weight loss is actually quality weight loss, making sure it's visceral adiposity that's lost, and trying to minimize any fat-free mass loss. So look after the muscles, the bone, etc. So I suppose that's a segue also to one of the components of your last question. Yes, the average general practitioner consultation is about 15 minutes. For my initial review with patients, I do allow longer time. But essentially, and we have published on this with Australian doctors for primary care, that we don't have to do everything in one consultation. I like to do like a mind map with my patients. I put their name in the middle and say, these are all the things that we've identified in our initial consult that we need to work on. And then I give them a highlighter and I turn around the paper and I say, out of all those things, which one is most important to you? And then inside my head, I'm going, oh, I hope they choose the one that I'm thinking is important. And sometimes yes, sometimes no. And sometimes I will highlight one and I'll say, okay, for today, we'll focus on one or these two. And then during the course of the upcoming weeks and months, we'll be chipping away at all these other things. And that way we're giving the patient a roadmap, because this is a chronic disease, and so it is a journey. And I remind them that this journey is fluid. We can change it, we can go here, we can go there, but at least they feel listened to. They feel that everything is important, but we had to prioritize certain things. So that has been a very helpful strategy.